Hello, welcome back to another informative show of Senior Matters. I'm your host, Greg Jamian, and today we'll be covering important topics that you won't want to miss, including treating chronic pain. So stay tuned, we'll be right back. Welcome back. I'm Greg Jamian, and you're watching Senior Matters. Today we have with us Todd Leininger with Paincare Associates in Bloomfield Hills, who specializes in the diagnosis and relief of acute and chronic pain. Dr. Leininger graduated from Wayne State University School of Medicine with honors in 1985. He then completed his pain management fellowship from Sinai Hospital in Detroit, Michigan in 1989. He has also completed his Master's of Art in Theology and Pastoral Ministry from the Mary Grove College in Detroit, Michigan, and Dr. Leininger is an Associate Clinical Professor of Anesthesiology at Wayne State University School of Medicine. He has a special interest in complementary medicine, reflex, sympathetic dystrophy, and the use of opiates for chronic and non-cancer pain. Welcome, Dr. Leininger.
Thanks, Greg.
Thank you for appearing on our show today. I find it interesting that you hold a master's degree in theology and pastoral ministry studies, as well as your degree in medicine, and as an anesthesiologist. Can you tell me how those two are related, if they are, and
Sure.
how you went down those two separate paths?
Sure, absolutely. I mean, really, I was always trained as a scientist, and science is really a very objective, black and white kind of thing. And what I found is taking care of people with chronic pain problems, there's really a lot more to it than that. And people's belief systems, their belief of why they have pain, how they see our world, how they see God. Are they being punished for something? It really becomes a very important part of taking care of people that are suffering on a daily basis. So that training was really very helpful, and I think giving me much broader insights into the human condition, separate from just a very scientific black and white kind of perspective.
Well, that's very interesting. I'm sure you get asked that question quite a bit.
Yes.
And let me ask you this, doctor. Is pain our friend? When we have pain, is it telling us something that we should know?
Well, that's a very interesting question. There's really two basic kinds of pain. I'm sure as we'll talk about some subgroups of pain. But we have acute pain and chronic pain. And acute pain is really a warning signal. And it basically is telling you, stop doing what you're doing. Or you're going to suffer from some type of tissue damage. And so the obvious examples would be touching something hot, we have a withdrawal response. We break a bone, we need to stop moving that part of our body so the bone can basically heal. So acute pain is a very good friend of ours because it really protects us. And in fact, there are people that are born with a very rare condition where they don't sense pain. And those people die at a very young age because they develop multiple types of injuries that subsequently cause infections, and the infections actually usually lead to their death. Those people rarely live beyond the age of 20. So without pain, we'd really be in a lot of trouble.
Well, that's really interesting. It's like paraplegics, a lot of times when they have an injury, spinal cord injury, below the injury, they don't feel pain, and they're prone to burning or not having the sensation to know when to stop doing something they may be further injuring themselves with. So that's very interesting. Is all pain the same, and should it be treated equal? You have aching, you got tingling, you got stabbing, burning, throbbing. Is pain, or is it different?
Well, there's really a couple different ways to think of pain. One type of pain is what we call somatic pain. And somatic pain is a kind of pain that you and I really experience almost on a daily basis. It's when we, hit our knee, we cut ourselves shaving, we just bump into something. That kind of pain is usually described as like aching, throbbing, and that's a normal type of pain. And those probably can be lumped together relatively well. A different type of pain is something called neuropathic pain or nerve pain. And nerve pain is usually described by things like sharp, stabbing, shooting. You'll often have numbness that accompanies neuropathic pain. And neuropathic pain is really a very different thing. It's very different in its mechanisms, that is what causes it and how the brain sees it. And the treatments are also very different. So one of our jobs is to take what are usually very complicated pain problems and kind of pick those apart and try to figure out how much of this is somatic pain, how much of it is neuropathic pain, and try to tailor the treatments to those specific conditions.
I see. In fact, one of the exhibits or charts that we have is a chart produced, I think, by the World Health Organization on identifying pain and measuring pain. And why is that important? Why is a chart like that so important? It has all the smiley faces on it and then some faces with frowns.
Well, the whole measurement of pain research and problem is really a very huge thing. And it is because pain is a subjective response. The only way that I can measure pain or measure your pain is what you tell me. So we try to look at how severe it is in really a number of different ways. And those scales, like most people have been asked a 1 to 10 scale. People are very familiar with that. That chart also shows like faces. That's what we call that a face pain scale, where you go from being like tearful to being happy. And you can choose where you are. And that's usually used for people who are either young, like children work well with that scale, or sometimes as there's changes in cognitive functioning as we age, those scales can be helpful.
Dr. Leininger, we started talking about the different types of pain there are out there, but first of all, I'd like to talk about acute pain. What is acute pain, and how's it differentiated from other types of pain, and what causes it?
Sure. Acute pain is really our warning pain system, and it's really caused by either tissue getting damaged or the receptors in our tissues being stimulated to the point where they're getting really, really excited. And again, that is really a warning mechanism. As that process takes place, like we have tissue damage, a bunch of chemicals are released, and probably a good example would be like a sunburn. You get a sunburn, your skin's red, your skin feels a little bit swollen, and the skin becomes very sensitive, and you're thinking like, why would something like this be painful? That's because of all these chemicals that are released and stimulating the brain.
I see. So other examples of acute pain would be, surgery, dental work, labor.
Labor, absolutely, is a form of acute pain. Surgical procedures, fractures, sports injuries, things like that.
And then one of the other types of pain that are most often noted is chronic pain.
Right.
Would you care to tell us a little bit about that?
Sure. Chronic pain is really, the way that we define it is pain that persists after something should have healed. And so you brought up a couple examples. Like if you break your arm, your pain should really be gone within 4 to 6 weeks, because that's how long it takes at an outside time period for that to heal and the pain to get better. If you're having pain at 2 months after a fracture, something's wrong. You probably have developed a chronic pain condition. What we know now is that, whereas I was saying before how acute pain is really a warning system, we have a lot of other words for chronic pain, and one of those is pathologic pain. We know now that the brain changes, and those brain changes actually make the pain persist. And so chronic pain actually becomes almost a condition or a disease by itself. Not that much different than diabetes, heart disease, or even people that suffer with long-term cancers.
Examples of chronic pain would be possibly a headache, low back pain, cancer, arthritis.
Yes.
Would those be good examples?
Those are good examples of somatic chronic pain. And then the neuropathic kinds of chronic pain, probably the most common in the United States is diabetic neuropathy, where our society, we have a lot more diabetes than we did, and now a lot of people are developing neuropathies from diabetes, and those can become very painful. Pain after shingles in the elderly population is very painful.
Would that be also neurogenic? What is
Yes.
neurogenic?
Neurogenic pain is really another word for neuropathic pain, which is pain that, again, comes from either an injury to the nervous system in some way.
I see. Now, we're going to be talking about the treatments for different types of pain in a few moments. But one thing I'd like to ask you about, are certain parts of the body more susceptible to pain? And if so, why?
Well, probably not necessarily a certain part of the body like the arm or leg, but there's really two types of very common chronic pain conditions in the United States. And the first is really back and neck pain, and that's because that part of the body goes under really a lot of wear and tear as we age. And so the discs degenerate and the spinal column can become painful. But the two really categories that we've already talked about, nerve injuries are much more likely to lead to chronic pain problems than are injuries to like your knee or to a bone or to soft tissues or muscles, for instance. So it's really the nerve injuries and the nerve pain problems that we really find most difficult to treat.
Now some people have told me before that, maybe the toes or other places have a lot of nerve endings, so therefore you feel pain more intensely in those areas than others. Is there any truth to that?
Sure. Our body really, the density of our nerves, or how many nerve fibers are in different parts of our body, are really in a way designed for what we use that parts of our body for. So like the middle of your upper back, it doesn't really do a lot, and so it doesn't need as many pain fibers as your index finger, which is very sensitive. So the concentration of nerve fibers, for instance, in the end of your finger is much, much higher than in the middle of your back, for instance.
Now, are there parts of your body that don't feel any pain at all?
Well, there are parts of your body that don't feel very much pain. And actually, as you get into the body, there are less pain fibers. So because if you think of it, our shell is really our protective mechanism. So most of our pain fibers are really on the outside of our body. Now,
it's a little bit beyond the scope of this discussion here today, but so in the event that you were having surgery and you had an incision and you were open and somebody stuck a needle in there to inject a fluid or something, you probably wouldn't feel that, would you?
Well, I mean, that's very interesting. I mean, say you were going to have you had some surgery in your abdomen. One of the most painful parts of that is going to actually be making the incision and cutting through the abdominal wall. Once the surgeon has made that incision and the abdominal wall is open, there's much less stimulation going on during the procedure inside your abdomen than even making that initial incision.
Now, a lot of people have foot surgery, and they say that that's very painful. And I don't know if it's because they're working on the podiatrists or physicians working on a bone or what, but are feet susceptible to a lot of pain?
Sure, and there's really a couple reasons. One is they have to support us, so there's a lot of weight bearing that the feet take place, that the feet are forced to do. It's a very bony structure. The outside of the bone, the covering of the bone are very painful structures. And then we do have a lot of nerves in close proximity.
It's very interesting. Well, we have to take a quick break, and we'll be right back with more from Dr. Todd Leininger in just a moment. Welcome back to Senior Matters. I'm your host, Greg Jamian, and we're here today with Dr. Todd Leininger, talking about treating your pain. Dr. Leininger, we want to talk this half a little bit about the treatment of pain. And are there certain types of pain that are more difficult to treat than others?
Sure. There's probably a couple of different rules. The first is longer the pain's been around, generally the more difficult it is to treat. And then the first half we were talking about nerve pain versus not nerve pain, or this thing I called somatic pain, like musculoskeletal pain. And as a rule, nerve pain tends to be much more difficult to treat.
I see. And your physician, of course, would tell you what kind of pain that is, or if they were to come to see you. And we will have a slide towards the end of the show on that. But let's talk about how pain is treated. I guess we also have a chart, a slide on the step process on how a physician proceeds going forward in treating pain. And you would start out with the lower end drugs and procedures like the Tylenol and aspirin and Advil and that sort of thing as you work your way up to your opiates and so forth. Can you just kind of take us through that process and what goes through your mind as a physician when you're treating a patient?
Sure. The thing I think to remember is that pain really needs to be treated in a holistic manner, really like in a comprehensive manner. And that means you have to deal with not only the pain but the person in pain. And so we really try to do an assessment that allows us to get a specific diagnosis as well as deal with any secondary issues, anxiety, depression, insomnia, other medical conditions that may impact the treatment plan. And so for musculoskeletal pain, which is the most common pain we treat, general health issues have to be addressed. So what's good for your heart, all these things we've been hearing about good heart care for the last 15 or 20 years, that's also good back care and it's good pain care. Mm-hmm. So that foundation of good health is very important. We know, for instance, that smokers have much more back pain than non-smokers. It's more difficult to treat, their pain is higher, and the degree of changes in the spine are actually worse than in a non-smoking population. So we have to deal with those health issues as well. So in addition to that, exercise, weight loss, physical therapy to recondition patients is very important. And once we really have a good foundation, that's when we would institute things like the World Health Organization ladder of analgesia or ladder of pain management. And you start with basic things like Tylenol or acetaminophen, aspirin, Motrin, and low-potency drugs. And then as those fail, or if those are inadequate, then you would add other more potent medications to them.
I see. Own personal experience, I had knee surgery a while back, and the doctor prescribed Vicodin as a post-operative treatment for pain. So I was on that for a day or two, and I found my pain coming back, and so I stopped taking the Vicodin and started taking ibuprofen, and that eliminated the pain immediately and completely, and it was just incredible,
Right.
How certain drugs work better than others, and even though the Vicodin is considered a narcotic.
Right. And the reason for that is in an acute pain, like a post-surgical pain, you really have a lot of tissue damage, and that tissue damage releases lots of different chemicals. And medications like Motrin are very effective at cutting down that inflammation, actually eliminating production of those chemicals that cause pain. Whereas a narcotic or an opiate like Vicodin, all that's really doing is changing your perception of pain at the level of your brain. So if you can focus on treating the underlying cause, you're going to be much more successful than just blunting the response to the pain.
Ibuprofen is really a good drug, good medication, and it really resolves a lot of problems for people, headaches, the minor problems, but sometimes not so minor problems as we just talked about. What are the side effects? Because I hear people that say, I take 4 Advil a day or 8 Advil a day, and that's ibuprofen. But are there any side effects that we should watch out for?
Sure. One of the things that we know now, and we probably remember a couple of years ago, we had Vioxx and Celebrex came out as big problems with people's heart. And what we've learned is that whole class of drugs all those anti-inflammatory drugs, they affect things like the way blood flows in your kidney. That can cause potentially kidney problems, and it can cause high blood pressure. It also changes the clotting factors in your blood, so there may be some risk in certain people with different types of heart disease. And then the other thing it can do is cause ulcers. So you do have to be careful. Those medications change the inner lining of the stomach, which can make you much more prone to ulcers.
So your advice is we shouldn't be alarmed about that, but we should be aware of it, and we shouldn't eat them like candy.
Exactly.
Like some people do.
Absolutely, yes. You need to be careful. The general warnings that are on the bottles when you pick up an over-the-counter drug tend to be conservative, but something you should follow. And if you're needing more than that, you really need to seek out advice from your physician.
As you step up the ladder, the next plateau would be what?
Usually what we call weak opiates, and so Vicodin, Tylenol with codeine. There's lots of different types of those, but that would usually be the next step.
And then the third step would
And then the third step is the potent opiates. Those are things like morphine, Dilaudid, fentanyl, things that are much stronger, and they're pure opiates or narcotics.
If you were experiencing pain, would someone go to their doctor and say, I want something natural versus synthetic? Because I know, like, for instance, morphine is natural, and then fentanyl is synthetic, from what I understand. I mean, does that play into anything, natural versus synthetic, or we shouldn't be concerned with that?
I don't think there's really any reason to be concerned with natural versus synthetic in that context. What you do need to understand is that we have our narcotic or pain medication receptors, mine are probably different than yours. So what works for me might not work well for you. And so when you look at large numbers of people, we really need to work with a physician who's willing to kind of, work with you specifically to deal with your issues.
Now, a lot of patients have secondary problems, liver, kidney, heart. Does that determine what kind of pain management regime they would be on?
Absolutely. All those conditions that you mentioned, the heart, not as much probably as the liver and kidney, but liver and kidney disease can make medical management of pain problems much more challenging. And heart disease can, because a lot of patients that have heart disease, for instance, are on blood thinners, and that takes away the opportunity of doing potentially procedures to people.
I see. Dr. Leininger, does age and gender play a role in the treatment of pain?
Yes. We know that probably the strongest risk factor for chronic pain is age over 70. And what we know is that because of these degenerative conditions, each decade of life probably is going to be more painful than the decade before, unfortunately.
So that's not good news.
But there are things that we can do to make that better. Not smoke, stay in shape, exercise regularly, and using the right nutrients and things for our bodies is very important. Gender is actually very interesting because there are studies that now. What's really fascinating is we have these things called PET scans or functional MRIs that look at the way the brain responds to pain, and we know that women respond to a painful stimulus different than different than men do. And for instance, women tend to respond to it with the more stimulation of the limbic system, which is an emotional part of the brain, and then men's limbic system doesn't light up to the same degree. And what that's going to lead to are treatments that are specific to that part of the pain problem.
Well, as the 80 million baby boomers, reach their golden years, I'm sure they're, as a group, they're a lot more active than the past era, and so treating sport injuries that's probably going to be a huge business, and there's going to be a lot of interest in that. What I'd like to do now is talk a little bit about addiction.
Sure.
Because there's a lot of people that have chronic pain that are on medications. How do we know when we've crossed the line and our bodies are starting to become addicted? Now, that's a common problem. People with back problems, we've heard of, actors, Jerry Lewis, and so on and so forth, people that have fallen prey to that out of necessity, of course. But how do you make a distinction between dependency and addiction?
The key things to remember is treating pain you should see three things: an improvement in pain, an improvement in mood, so less depression and anxiety, and improvement in function. And if you see people that are using medications and you're not seeing those things, that would be an early sign of a problem. The other thing that we really focus on is a term called loss of control and continued use despite harm. And those basically mean that someone who's unable to control their use of their medications, if I give you a month's worth of medication, you're out of them in 10 days, you have a controlling your medication issue, and that's probably now addiction versus dependency. Dependency is common with lots of drugs. Blood pressure medications, antidepressants, heart medications, all can cause dependency. And all that means is that when you stop them suddenly, your body has a withdrawal response to that. And that happens with pain medications as well. So it's really behaviors define addiction, and withdrawal really defines dependency.
Now, is that your doctor's responsibility to identify that, those differences? Or?
Well, I think it's your doctor's responsibility, but it's also your responsibility. I think that it's important for you to understand that when you're using these medications, they can be good, they can be bad, and it's balancing those things together.
Dr. Leininger, you've been in the practice of medicine for quite a few years. What do you see that's cutting edge out there as far as the treatment and pain management, and are you doing any of them any of that cutting edge therapy in your office?
Well, the cutting edge things are really based on understanding what causes pain and new therapies that are coming out. So probably the most high-tech cutting edge thing that we do is using a toxin from a South Pacific snail that actually we infuse into the spinal fluid that blocks the pain message.
We have a contact slide on how to get a hold of Dr. Leininger that we're putting up right now, and he's got an incredible practice as we learn about this snail. Tell us more.
Well, I mean, basically there's a snail in the South Pacific that eats fish. It's this big giant snail. It's about as big as a carton of milk. And that toxin actually can block pain when it's administered to humans in very, very low doses. And there's lots of these interesting toxins coming onto the market from other snails, frogs, those really pretty frogs that you see in South America. The toxins that they produce are very good pain medications. So there's lots of very interesting things coming down the road now.
And we haven't even gotten into the pain pumps and the apparatus for application and all that, but those are all things that are available. And how can people get a hold of you?
Our office is here in Bloomfield Township. We're just around Telegraph and Square Lake. Our phone number is 248-751-7246.
And we also have a slide up there on that as well. Now, Dr. Leininger, we're here with Dr. Todd Leininger. Do I need a referral to come and see you? Assuming that I don't have one of those kinds of insurances that require me to have a referral, can anybody just come and make an appointment with you?
Sure. Yes. I mean, we would want to gather all your medical information from the doctors that have been taking care of you, but no, we can see you without a referral, absolutely.
Well, I want to thank you very much for coming in today, and I'd like to also thank our show sponsors, Drexel Heritage, Hagopian World of Rugs, and Paincare Medical. My name is Greg Jamian. You're watching Senior Matters, the show where seniors matter. Thank you.
Thank you.